The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. We are here for the next episode of TMD Demystified, and my name is Tony Urbanic. I hope to enlighten you today about a continued issue within the parameters of treatment of TMD that is very important, very critical, actually, to the health and welfare of the millions of people, primarily females, who have TMD throughout the United States and certainly throughout the world. The issue really revolves around the fact that physicians are, for the most part, not aware at all of TMD, its symptoms, the effect that this has on patients, and when they are aware of it, under whatever circumstances, then they basically immediately wash their hands of it and give it one way or another, refer it one way or another to the dental profession. So I assume if you are watching this episode and you are tuned in to watching TMD Demystified, that you are in the dental profession, not the medical profession. So why am I talking about what physicians need to know and don't? Well, we'll cover that at the end and actually how to fix that very specifically. So the title of this episode is going to be What Physicians Need to Know About TMD But Don't. What physicians need to know about TMD but don't. And then we'll talk about how to solve that, because let's look at it logically this way. As a dentist of one kind or another, or a dental specialist, or dental generalist, general dentist, whether you like it or not, you have the responsibility to treat TMD. Now, again, admittedly, more than half the population of dentists in the United States don't want anything to do with TMD. They hear the word TMD and they shut their ears or walk the other way, roll their eyes, or hope the patient goes somewhere else. I acknowledge that, I admit that. That doesn't make it right, but that is the fact. My goal is to, one way or another, encourage the dental profession to take on the full responsibility of treating TMD correctly, because, frankly, there is nobody else that's going to do it. The medical doctors are not interested. We can talk about that even as a separate episode. So whether or not you feel you want to get involved, or, not get involved at all, that's certainly an independent personal decision. But the fact is, the dental profession had it dumped in their lap, actually unintentionally, and the dental profession hasn't done a good job at treating TMD. And that is a logical conclusion, because the consensus out there is that among dentists and physicians and patients, that nothing regarding TMD is effective. Nothing works. Well, we've proven that otherwise, but again, getting to the point. So let's go down this road about what physicians need to know about TMD, and then we'll talk about actually how to change that and correct that. Pretty simple. So first of all, what do physicians need to know that they don't know? Well, first thing they need to know what the symptoms of TMD are so that they can place them on their list of differential diagnosis. I think I've discussed this a little bit in another episode before, but medical doctors and dental doctors think a little differently about how they make a diagnosis, but factually, a diagnosis is made the same way, whether you're a dentist or a physician. And, having that knowledge and running both rails as both a dentist and physician became very obvious to me. But physicians think like this. They have a patient come in and with complaints. They have a new patient, new consultant, a patient comes in with complaints. And those complaints are nothing more than symptoms. And the doctor, first of all, if he's a good physician, he will listen to the patient's symptoms and then expand on by questioning to determine if there are other symptoms that are present. But symptoms are nothing more than red flags. You do not make a diagnosis on symptoms. Symptoms actually create in the mind of the physician a differential diagnosis, a list of symptoms, whether they be 2 symptoms or even 1 symptom or 15 symptoms, will create in the mind of a consultation with a physician. He will start thinking about, well, what is the differential diagnosis on these symptoms? What could this be? The dentist, on the other hand, is used to having very limited differential diagnosis, unless, you're looking at oral pathology from the standpoint of soft tissue pathology, and you get into oral pathology and oral pathologists and that kind of thing, which I'm very familiar with as an oral maxillofacial surgeon. But the average general dentist or even dental specialist, endodontist, periodontist, pedodontist, doesn't have a differential diagnosis. He'll take one look in the mouth and he will see some decay, or he'll see some periodontal disease, or he'll see a missing tooth, or he'll see a malocclusion, orthodontics, and he will know exactly what direction to go. He's made the diagnosis. The orthodontist has made the diagnosis malocclusion. The general dentist has made the diagnosis of missing tooth, put in a dental implant. A to B, straightforward. There is no differential diagnosis. But the physicians think quite differently, and a differential diagnosis is number 1 on their mind when they do a consultation with a patient. So what the physicians don't know is they don't know that TMD should be placed on their differential diagnosis when they talk to a patient. And what are the symptoms that patients give or state, that stand in front or sit in front of a physician as they discuss their problems? What are those symptoms that should trigger a thought about TMD from the physicians? Well, as if you followed these episodes at all, you already know that I'm going to spiel out the symptoms of TMD, which are well-accepted symptoms. There are a few others that are less unique, that are pretty unique, that I will not note. But the usual and customary symptoms, well-known, well-established, well-accepted of TMD are frequent or recurring headaches, earaches, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, feeling of fullness in the ears like you've been swimming and can't clear your ear, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Various descriptions of, I can't open my mouth, my jaw's locked, it's partially locked, whatever. Now, that last one actually would lead a physician to immediately say, this is out of my ballpark. You must have something wrong with your jaw. Go see your dentist. And that's what I hear all the time from patients. But in any case, those are the symptoms of TMD. And the physicians are not aware at all of most of those symptoms having to do with TMD. If they have a patient in front of them, or a physician's assistant or a nurse practitioner has a patient in front of them with ear pain, they're going to look in the ear and look for ear infections. And frankly, most physicians' assistants and nurse practitioners, unless they work in an ENT office, are going to miss the diagnosis. And whatever they think they're looking at, the best example is nurse practitioners, physicians' assistants who work in immediate care clinic, walk-in clinics, will tell the patient they have an ear infection no matter what they're looking at through the otoscope. How do I know that? Because I see all the patients all the time who have done that and gone to 2, 3 walk-in clinics, different walk-in clinics, or maybe the same walk-in clinic and the same practitioner. And every time they go in, what do? They get a prescription for antibiotics because they're told they have an ear infection when actually the ear pain is coming from TMD. That's just one example. And general physicians are not a whole lot better at looking at ears. If you're an ENT doc, you're an ENT physician assistant, then you're more likely to pick up the fact that there's nothing wrong with that ear. The tympanic membrane looks really good. It's not red, it's not swollen. You do not have an ear infection. Well, then they go the differential diagnosis. Well, what else could this be? Unless they live in Middle Tennessee, most of them don't even think of TMD, but I can tell you all the ENT doctors, or at least most of the ENT doctors in Middle Tennessee now think of TMD when they see patients complaining of ear pain without an actual ear infection, just as an example. So what are the physicians, what don't they know? They don't know that, quote, migraine headaches are a symptom of TMD. That upper back and shoulder pain is the neck and upper back and shoulder pain is the second most common symptom of TMD. That is a fact. Headache, number one, neck pain, upper back, and I say upper back, not lower back, are symptoms of TMD. So they make the diagnosis, they misdiagnose all the time. And if they misdiagnose it, they miss the correct diagnosis, but put a incorrect diagnosis on it, the patient is going to see some kind of treatment that doesn't apply. That's really important. I hope you see that. The second thing that physicians don't know that they need to know is that TMD is actually the same phenomenon that occurs with tennis elbow. And I've explained that in a separate episode, basically entitled TMD and tennis elbow are the same disease. But if they really understood that, if they understood that inflammation of the moving part of a joint, the inflammation of a moving part of a joint, whether it be temporomandibular joint or elbow, can create the effect of muscle tightness and trismus that moves that joint. That's what tennis elbow is. That's why tennis elbow patients complain of tingling and pain and numbness of their forearm all the way down to the wrist at times, which is the same phenomenon that occurs with the temporomandibular joint. When it becomes inflamed, it causes the muscles of mastication, then the muscles of the neck, then the muscles of the upper shoulder girdle to get tight, which is why the second most common symptom of TMD is neck pain and upper back and shoulder pain. Physicians don't know that, and you know that by listening to this episode. So basically, the physicians don't know, and they don't know what they don't know, that those symptoms should be placed on their differential diagnosis. The specifics of what they don't know and should know is that bad headaches, bad recurrent headaches, actually the first thing that they need to consider when a patient comes in and says, I have bad headaches, and whatever their description and timing is and whatever, TMD should be toward the top of the list in their differential diagnosis. And most of the time, unless they're enlightened, and we're going to talk at the end again about how you enlighten the physicians as a dentist effectively. How can you enlighten physicians and nicely with being very professional about it? But the point is that bad headaches are always called migraines because of television, because of physicians, because they're, drugs are peddled constantly, a headache being the actually most common complaint of patients throughout the world. Headaches is the number one symptom that people complain about. And when they complain to a physician, I can tell you with experience, and I'll tell you why, the first thing the physician thinks about is, does this patient have a brain tumor? Or what are the potential the patient have a brain tumor when they have bad headaches? It's likely, I don't know, I will not quote the exact statistic because I'm sure there are different statistics on that question, but it's probably in the realm of 0.001% of patients who complain of bad headaches have a brain tumor. But I can tell you with experience, the first thing the physician is going to do, he's going to order an MRI, ka-ching, for $2,000 to $3,000 for someone who complains of bad headaches, recurrent, unresolved bad headaches. How do I know that? Because a couple of years ago, I lectured to a room full, about 30 family physicians, and I posed this question to them. If you see a patient who comes into your office with recurrent bad headaches, complaining of severe pain in and around the head, what's the first thing that you will do? And every one of them, of the 30 in the room, agreed the first thing they would do was order an MRI looking for brain tumors, when the potential of a brain tumor is absolutely low. And what they don't know is if they have bad headaches, if they do this and push on the joint from the open and closed position and it hurts, it confirms the diagnosis that it is not a migraine headache. It's a headache coming from inflammation within the temporomandibular joint. And physicians don't know that, at least outside of the arena, for the most part, of Middle Tennessee, which Middle Tennessee doctors are well aware. That is why in our practice here in Middle Tennessee, we have over 800 referral sources, half of those referral sources for TMD services, with TMJ patients being referred in. Half of those are physicians, nurse practitioners, and physician's assistants. Next in line is Meniere's disease. Meniere's disease, one way or another, will get funneled down to the ENT doctors, wherever it starts out in the medical lineup, and patients will complain of ringing in their ears, feeling of fullness in their ears, subjective hearing loss, vertigo, and dizziness. It can be all three. It can be only one of those three. But if you complain to a physician, a nurse practitioner, or physician's assistants long enough about those symptoms, and they give you whatever kind of medication they think is going to help, and it doesn't help, you will end up to an ENT physician, specialist in otolaryngology. And the otolaryngologist will do a workup. He'll listen to the complaints. He will form a differential diagnosis of symptoms. TMD is unlikely to be on that list unless you now practice in Middle Tennessee. And then they will do a workup with another MRI, maybe a CT scan, looking for specific things about the hearing mechanism. They'll probably send you to an audiologist and create a bill for anywhere between $2,000 and $4,000 to do the workup. At which point, if they don't find any tumors or they find no infection, the MRIs and the CT scans come back normal, the ENT doctor will say, well, you have Meniere's disease. That's what we call the symptoms of ringing in the ears, subjective hearing loss, and vertigo. We call that Meniere's disease. And the patient will say, well, great, doc, what can we do about it? And the ENT doctor will shake his head, roll his eyes, and say, we do not have a solution for Meniere's disease. the ENT doctors, the physicians, don't know what causes Meniere's disease. They define Meniere's disease by the symptoms, not by the cause. Same thing with migraine headaches. I've noted before that the symptoms of migraine headaches, when they occur and studied, the good science, good scientists, great papers, the first thing that they say when they discuss migraine headaches is we have no idea what causes migraine headache. I just read a lengthy paper that the paper's attempt to debunk all of the previous theories about migraine headaches and present its own independent theory. I won't go into that. That'd be another great episode if it gets pretty technical, but the people who study migraines, and first of all, admit they have no idea what causes migraines. So you're dealing with major symptoms with patients, Meniere's disease, migraine headaches, and the medical profession, the medical establishment admits they have no idea what causes these two very frequent, sometimes very severe and life-changing symptoms. The third one on the list is earaches. That's easy. I already discussed that. Patients come in, they say, my ear pain, I got ear pain. They look in the ear, there's no infection. If the wrong practitioner looks in it, they say, well, you must have an ear infection, here's some antibiotic. So the physicians and the physician establishment has a long way to go in understanding TMD, and what they don't know, they don't know. The next thing the physicians don't know is that it's such a big problem. I mean, they see a very specific, put the blinders on, and they see a very specific number of patients per day or per week or whatever. But what they need to know is that 45% of females have temporomandibular joint symptoms of one kind or another throughout their life, getting worse over time. Usually starts out in the teens, early teens. Estrogen exacerbates inflammation, which is the reason that once young women start their menstrual cycles and they start the cyclical estrogen cycle, they begin, and if they have inflammation or damage within the temporomandibular joint, then inflammation will cycle, at which point it will bring on symptoms. Physicians don't understand that, and they don't understand how big the problem is. 45% of females. The literature, the dental literature that studies that has studied TMD will give you numbers, and there are multiple studies out on this issue, anywhere between 15 and 30%. But they are not including, all those studies do not include all of the symptoms. All of those studies do not include tinnitus, subjective hearing loss, and vertigo. They haven't included upper back pain or arm, hand, finger tingling and numbness. So when all those are added to the other accepted symptoms of, jaw pain and facial pain and neck pain, when you add all those together, we're up to 45% of females. I can promise you that if you have 10 females in the room, at least 4 of them, or not 5 of them, will raise their hand if you list those symptoms and you ask how many of you have one or more of these symptoms currently. 45% of them will raise their hand. That is a large number of people, and physicians see it and overlook it all the time. Whether they hear the symptoms or not, they're not looking for those symptoms. So how do you fix this? Well, I'm going to spend a couple minutes on that. I've discussed this already, but I'm putting all of these features together in one episode to make the point of what physicians don't know, and then how the dental profession, how you, doctor, dentist, can actually fix this for your patients and your community and the United States of America, and do it in a way that's totally acceptable and gets the job done. So what we've learned to do in our practice, and I promote among other doctors who use the Urbanic device and protocol, is to do the same routine. It's a marketing routine, which is really, I don't like the word marketing. Awareness is a much better word, much better word, because that's all you're doing with marketing. You're making people aware, and you can do it well or you can do it poorly. But if you do it well, all you're doing is making people aware and, throwing out the seeds, and hopefully a certain number of those seeds will fall on fertile ground, to be biblical. So how do you do this? Well, as you begin to see patients with TMD and they filter in, or you can do simple things like send out brochures to the wherever, whether they come through patients or whether they come through other doctors, or your dental colleagues find that, well, you like to treat TMD. Well, I can promise you're going to get a lot of dentists referring you patients for TMD problems. But basically, once you begin to see those patients, you collect it at your reception desk, a list of all the doctors, physicians, nurse practitioners, physician's assistants, chiropractors, massage therapists, other dentists, other oral surgeons, whatever list that patient has of doctors that they have seen for any reasons, but especially the reason of the symptoms that they think are associated with their jaw joint problem. You take that list, and every time the patient is seen and seen for the delivery of the device, or when they're seen after delivery to check how much of these symptoms are decreased or diminished. That's the key question. What percentage of your overall symptoms are diminished, decreased, or gone away? And they will give you a number between 0 and 100%. And a letter is generated to each of those doctors on the original list that the patient registers in with and gives your receptionist. You got to ask for the names, or they won't give them to you. But you make your receptionist get those names, and letters are sent, snail mail letters are sent to each of those doctors, which describes the point that the patient is seeing, delivery of the device, the 3-week post insertion check, the 9-week post-insertion check, the 4-month post-insertion check, and occasionally the 6-month insertion check, because patients hardly ever come back after 6 months. Once they're fixed, you can't get them back in the office. But a letter goes out to all those physicians and medical providers of various kinds, or your dental colleagues, if that's the case, and expresses what the patient's symptoms were, listing out the symptoms, and what percentage of those symptoms are not diminished or decreased by the patient's subjective statement, not your opinion, the patient's opinion. And it's an opinion. That's what I tell people. I said, just give what percentage of all of those symptoms are not diminished or gone, in your opinion. You can't be wrong because it's an opinion. It's your opinion. And they eventually will give you a number. That number goes on the letter along with the list of symptoms, and every time the patient comes back for a post-insertion device check, those letters go out. And within a short time, the physicians, the medical establishment in your community will first of all, they will learn the symptoms, and they will learn that there is a solution, and they will learn what the solution is, and they will start to send you patients for TMD. That's how it works, and that's how you solve the problem. That's how you get the patients to learn what they need to know that they don't know. It's quite simple. It's really simple. It's really simple. Nothing we do here is complicated. I was surprised when I learned what was really going on with TMD, and it's all related to inflation and not some myofascial kind of theory. It's all related to inflation, and how do you get rid of inflation? You unload the joint. It's not complicated, but you have to unload the joint correctly. You got to use a proper device long enough that they can do that. That's the Urbanic device and protocol. I encourage you to find out more. I encourage you, if you'd like to add this to your practice, you certainly can find out more at www.urbanictmj.com. If you'd like to talk to me personally, I'm available. I can be reached at tony@tmjservices.net. My director of marketing and education, Dr. Naomi Williams, can be reached at Naomi at naomi@tmjservices.net. I really encourage you to think about adding this to your practice, taking responsibility for treating TMD. It's quite easy. It's not complicated. Everybody's out there thinking this is really complicated. The patients are complicated. The problem is complicated. And the solution must be really, really complicated. And there are plenty of dentists out there who want to make this complicated, but it's not complicated. Enough said for today. I really look forward to speaking with you in a week during our next episode. I am Tony Urbanic, and this is TMD Demystified.